Yes, good evening, everyone. Yes, Sai Taruni, good evening. Right. So let us start with today's session on the clinical based questions. So in order to see that you should not face any difficulty in the upcoming FMGE exam, we at Arise Medical Academy have come up with the clinical based discussion. We'll ensure that you should not face any difficulty in this FMGE exam. So now let us start with the discussion. So the first question is, the first important clinical based question. We have a 36-year-old woman presents to the rheumatology outpatient clinic with 2 months history of stiff hands and as well as stiff wrist. She mentions that the pain is particularly bad for first few hours after waking up and is affecting her work as a dentist. On examination, the wrist, metacarpophalangeal joints and proximal interphalangeal joints are swollen and warm. What will be the cardiac examination finding in this patient? Ejection click, tumor plop, pericardial knock, loud S1, opening snap. Yes, Mohammad Faizan, good evening. I'm fine, thank you very much. And I hope the same from you as well. Yeah, so who will be the first person to answer this? Very good. So the answer to this question here is, so Sai Tarni has answered it first. So the answer is the pericardial knock. So what exactly is the diagnosis? See, this particular patient is suffering with the rheumatoid arthritis. Right? This particular patient is suffering with the rheumatoid arthritis. And what are the features of rheumatoid arthritis? Like the presence of stiff hands and as well as wrist. And along with that, she also says on examination, what has been found is metacarpophalangeal joints and proximal interphalangeal joints, they are swollen and as well as warm. And what will be the cardiac examination finding in this patient? See, in patients with rheumatoid arthritis, let me tell you that this individual can develop what is called a cardiac complication called constrictive pericarditis. And what type of constrictive pericarditis you will see in these individuals? You will have the development of the chronic constrictive pericarditis. Right? You will have the development of chronic constrictive pericarditis. So in constrictive pericarditis, like what is the cardiac examination finding? In constrictive pericarditis, on auscultation, you will have muffled heart sounds. Right, you will have muffled heart sounds. That is one important thing. And an additional sound is heard in constrictive pericarditis. And that additional sound is pericardial knock. Right, the additional sound, whatever you listen, is nothing but your pericardial knock. And remember, this pericardial knock, it is a diastolic sound. Right, this pericardial knock, it is a diastolic sound. Okay, right. Now, what I wanted to tell you from this particular question is, until unless you are aware of the complications of rheumatoid arthritis, you cannot solve this question. So, to crack this question, what you should know the cardiac complications of rheumatoid arthritis. So, the cardiac complications of rheumatoid arthritis is the pericardial knock. So, that's an important take-home message in this particular question. right? Now, what about the other sounds? You take the ejection click. Ejection click, you will listen in aortic stenosis and as well as pulmonary stenosis. Tumor plop, you will see this or you will listen in patients with the atrial myxoma. Right, in patients with atrial myxoma. Next, pericardial knock. This is like what you will listen in constrictive pericarditis. Now, what are the clinical conditions? You will have this loud S1. Loud S1, you will listen in patients with mitral stenosis and tricuspid stenosis. And the opening snap also follows the same. Opening snap is also heard in the mitral stenosis and as well as the tricuspid stenosis, right? So this is about this very important, the clinical based question. So what is the take home message from this question? Take home message is only one line. Cardiac complications in rheumatoid arthritis is constrictive pericarditis. So if you can understand that one single point, then you can answer this question very easily without any difficulty as pericardial knock. All right, next we will move on to the next question. Yes, this is another image based question, very important. A hypertension patient is having severe chest pain, after which he developed unilateral ptosis and hemiparesis. The chest X-ray of the patient is shown below. What is the clinical diagnosis? Aortic dissection, acute myocardial infarction, cardiac rupture, atrial fibrillation with embolic stroke. Yes, may I know who will be the first person to answer this? Okay, so Tenso says embolic stroke. Okay. Any other answer apart from the embolic stroke? No, I did not get the correct answer from any one of you. Right. So let me tell you what is the important chest X-ray finding you are able to make out. The important chest X-ray finding you are able to make out is widening of the mediastinum. Right, you are able to make out that there is widening of the mediastinum. Very good. So some of you are answering it. So the answer is the aortic dissection. Now, what is the condition where you have the widening of the anterior mediastinum? One of the conditions where you can have is in case of the aortic dissection. All right. Next, the other point is the patient is having severe chest pain. The presence of severe chest pain, you can have that even in patients with the acute myocardial infarction. You can have that even in patients with a cardiac rupture. But how will you rule out acute myocardial infarction? How will you rule out acute myocardial infarction in this case? See, there is no, the chest X-ray, I mean lungs, if you see, lungs are absolutely clear. Right, lungs, they're absolutely clear in this patient. So when the lungs are absolutely clear, that rules out the presence of the pulmonary edema. Right, the lungs, they are clear. That rules out the presence of pulmonary edema. Okay. Now, in case of acute myocardial infarction, one of the complications what you can have is pulmonary edema. So pulmonary edema is not there in this patient. So that acute myocardial infarction can be ruled out. Okay. Now, in patients with acute myocardial infarction, unilateral ptosis and hemiparesis need not occur, but it will definitely be seen in patients with aortic dissection. In aortic dissection, you can have this particular unilateral ptosis and as well as the hemiparesis. And the question is why? So the point is that, for example, if the dissection is occurring in the aorta where you have the supply to the upper limb and as well as the lower limb, then in such case you can have the hemiparesis. And In atrial fibrillation, you will not have the widening of the mediastinum. So if you see the chest X-ray, you have the widening of the mediastinum. This widening of the mediastinum, you will not see in case of the atrial fibrillation. So that is the reason why atrial fibrillation is ruled out. And many of you are thinking that the embolic stroke would have resulted in hemiparesis. But in this case, it is not. In this case, it is not. Why? Because the very classical picture in the chest X-ray is widening of the anterior mediastinum, which you will see in patients with the aortic dissection. So this is one of the very, very important point, right? Next, can anyone tell me what is the drug of choice for reducing the blood pressure in patients with aortic dissection? In reducing the blood pressure and as well as reducing the heart rate, because in aortic dissection, what do we want? We want that the blood pressure and heart rate should be reduced, because if you don't reduce the heart rate or if you don't reduce the blood pressure, that will further precipitate the aortic dissection. So can anyone tell me what is the drug of choice? Any one of you? Very good, Tenso, excellent. So you need to give esmolol, super. Right, you need to give esmolol. Okay, so esmolol is the drug of choice. That is the one which will reduce the heart rate of the individual, right? And why preferably esmolol? Tenso, why do you want to give esmolol? Why not the other drug? Why you want to give esmolol? The reason is that esmolol, it is a quick and a short acting drug. Right, it has a quick onset of action and it is a short acting drug. So thereby it will reduce the heart rate of the individual and as well as the blood pressure, and see that the precipitation or progression of the aortic dissection does not occur, right? So that is about the clinical question on the aortic dissection. Now you may ask me, sir, why not cardiac rupture? See, in cardiac rupture, these individuals, they will have a collapse. That is, in the sense, they will have hypotension. Right? They will have hypotension and they will have cardiovascular collapse. But what is given in our question? A hypertension patient. That is what is given. So that is the reason why your cardiac rupture will not be the answer in this question. So the answer is aortic dissection. All right. Now, we will move on to the next clinical based question. So now what is a take home from this message from this question? The take home message is that in aortic dissection, in chest X-ray, you will have widening of the anterior mediastinum. So this is one point which is a take home message from this question, right? Next. Yes, so the question looks lengthy, but the answer is very simple, right? The question looks very lengthy, but the answer is very simple, right? Don't get scared by seeing these lengthy questions. And these are the questions which you will be getting in your upcoming exams. And we at Arise Medical Academy are seeing that you should not have any difficulty in facing these type of clinical based questions, okay? Right. So we have a 68-year-old female with history of hypertension, diabetes, and the coronary artery disease. And the other point is that she underwent, so coronary artery disease. And for this coronary artery disease, she has underwent coronary artery bypass grafting 20 years ago, right? 20 years ago, she underwent the coronary artery bypass grafting. And she presents to the emergency room with increasing shortness of breath and lower extremity edema. So two main complaints. Number one, shortness of breath. Number two, lower extremity edema. Her temperature is 37 degrees centigrade and blood pressure is 110/70, heart rate 110, respiratory rate 20. Physical examination reveals cachectic appearance, marked jugular venous distension, worse with inspiration. This is an important point for me, right? Marked jugular venous distension, worse with inspiration. Decreased breath sounds at the left base, pulmonary rolls throughout the lung fields, a regular rhythm with an extrasystolic heart sound. Hepatomegaly, ascites, 3+ pitting lower extremity edema above the knees. ECG is normal. Laboratory investigations showed elevated AST and ALT and total bilirubin. Hepatitis profile is normal. Which of the following is the most likely etiology for this condition? Tuberculosis, sarcoidosis, histoplasmosis, post-radiation, post-cardiac surgery. Okay, so first of all, can anyone tell me what is the diagnosis? What do you think is the diagnosis? You please tell the diagnosis and then tell the answer. Now, who will tell me the diagnosis first? Yes? Who will be the first person to tell me the diagnosis? What is the diagnosis of this clinical condition? Why are you people answering it as post-cardiac surgery? Some of you are answering as sarcoidosis. Why are you answering that? So without diagnosis, you should not come to the etiology. Right ventricular failure. No. So yes, Vaibhav Trivedi, you are telling right ventricular failure. In right ventricular failure, do you have shortness of breath? In right ventricular failure, do you have shortness of breath? You will not have shortness of breath in case of your right ventricular failure, right? Yes, anyone? Right. So now let me tell you the diagnosis and then go ahead. See, this patient is having a feature of left heart failure and a feature of right heart failure. Right? Now, can anyone tell me what is this sign? What is this sign? Jugular venous distension worse with inspiration. Yes, can anyone tell me what is this sign? Jugular venous distension worse with inspiration. Very good, Sai Taruni. So this is called Kussmaul sign. Yeah. Now you people tell me now. What are the conditions where you will have Kussmaul sign? Yes, Sai Taruni. Now you tell me. What are the conditions where you will have the Kussmaul sign? What are the conditions where all you will have the Kussmaul sign? So you will have the Kussmaul sign in no. In left ventricular failure, you will not have Kussmaul sign. Very good. So Gangula Akanksha, good. So it is seen in case of constrictive pericarditis. Next. In case of right heart failure. Okay. Next. One more condition. The other one is restrictive cardiomyopathy. Right? Restrictive cardiomyopathy. So these are the conditions where you will have Kussmaul sign. Right? Now, this is not your right heart failure. This is not your right heart failure. Why? Because the patient is also having the features of left heart failure. The patient is also having the features of your left heart failure. So that is the reason why this is not the diagnosis of your right heart failure at all. Now, either it should be constrictive pericarditis or it should be restrictive cardiomyopathy. Now, going to the question here, what all the patient is having? Hepatomegaly. Ascites is there. Then along with that, there is also lower extremity edema. And if you take the AST and ALT both are grossly elevated. And along with that, there is also increase in your total bilirubin. Now, where do you have that? You will have that in patients with a constrictive pericarditis. Right? You will have that preferably in constrictive pericarditis. And no. Yes, Sai Taruni, let me just clear some of the confusions for you all. Kussmaul sign is absent. Right? Kussmaul sign is absent in case of cardiac tamponade. and it is also absent in superior vena cava obstruction, SVC obstruction. So in these two conditions, you will not have the Kussmaul sign. In these two conditions, you will not have Kussmaul sign. That is in cardiac tamponade and as well as superior vena cava obstruction. All right. Now, yeah. So now the other important thing is now the diagnosis should be either constrictive pericarditis or the restrictive cardiomyopathy. Right, constrictive pericarditis or restrictive cardiomyopathy. So what would be the cause of either of these conditions? Both of them are diastolic dysfunction. The cause for either of these conditions is post-CABG. Post-CABG is the one which is responsible for the development of diastolic dysfunction in this patient and giving rise to, and the answer to this question is the post-cardiac surgery. Right, the answer to this question is the post-cardiac surgery. And what is the diagnosis? As already I have said you, diagnosis is constrictive pericarditis. And what is the cause for the constrictive pericarditis? That is your post-cardiac surgery. Right, the cause for the constrictive pericarditis is post-cardiac surgery. So this is the clinical question related to your constrictive pericarditis. Right. Now, I will just summarize everything and I will give you take-home message from this question. Now, what is a take-home message from this question? Only one line. That is, one of the etiology of constrictive pericarditis is coronary artery bypass graft in the past. That is one important take-home message I want to tell you. And second important take-home message from this question is, the most common cause of constrictive pericarditis in India is tuberculosis. Right? Most common cause of constrictive pericarditis in India is tuberculosis. Right? So this is the take-home message from this particular clinical question. Okay? Right. Now we will move on to the next image-based question. Yes. So yeah, very important question, and it's an integration actually. It's an integration of your physiology and as well as general medicine. Which of the following conditions can be probable diagnosis for JVP recording mentioned below? Constrictive pericarditis, cardiac tamponade, cor pulmonale, cor triatrium. Yeah, so answer this please. Which of the following conditions can be a probable diagnosis for the JVP recording mentioned below? Tenso is saying cor triatrium. No. It is not cor triatrium. Any other? So you correlate your Venkatakishore says cardiac tamponade, okay? Sai Taruni says cor pulmonale. Only one option is left out, okay? That is constrictive pericarditis. So answer is constrictive pericarditis. Answer is constrictive pericarditis, not cardiac tamponade. In cardiac tamponade, right? In cardiac tamponade, remember in JVP, you will have prominent Y wave and there is no X descent. In cardiac tamponade. But in JVP, if you see here, you are having X wave, which is prominent. You are having Y wave, which is prominent. So what is the condition where you will have prominent X and as well as Y descent? So in constrictive pericarditis, you will have prominent X and as well as Y descent. You will have prominent X and as well as Y descent, right? So yes, so this is the JVP finding correlating with ECG. Now, how will you correlate with the ECG? I will tell you. What is your A wave in your, what is your A wave in JVP? A wave in JVP is your atrial contraction. So now you correlate that with the ECG also. You correlate that with the ECG. You correlate that with the ECG also. A wave is your atrial contraction. P wave is your atrial contraction, which is correlating. Right? Now, you take the X descent. X descent is what? It is your atrial relaxation. X descent is your atrial relaxation in the JVP. Okay, now when atria is relaxing, what will be your ventricle doing? Ventricle will be contracting. So when ventricle contracts, what is that you will have? You see, this is your X wave, your atria is relaxing. And when atria is relaxing, the ventricle will contract. And when ventricle contracts, what is that you will have in the ECG? You will have QRS complex, right? You will have the QRS complex, okay? And if you take the X descent, it is deep here. And even if you take Y descent, this is also very deep. So where is that you will have deep X descent and as well as deep Y descent? You will have that in patients with the constrictive pericarditis, right? In cardiac tamponade, you will not have X descent at all. Sorry, you will not have Y descent. I don't know. I think I have said reverse previously. I think I'm very sorry if I have said reverse. There is no Y wave in cardiac tamponade. But in cardiac tamponade, you will have deep X descent. So if I have said reverse previously, please correct it. If I did not tell, then just it is the same. There is no Y wave in cardiac tamponade, but there will be deep X descent in case of the cardiac tamponade. But here if you see, you have a deep Y wave. Here you have a deep Y wave. So presence of deep Y wave will rule out your cardiac tamponade. Right? Will rule out your cardiac tamponade. Right? Now, we will move on to the next important clinical question. Yes. So this question is slightly obstructing. Yeah. Now I hope now you can see the entire question properly. We have a 57-year-old male presented to, right, 57-year-old male admitted complaining of headache and blurring of vision. His blood pressure is found to be 240 by 150 millimeters of mercury and he has bilateral papilledema, right? Bilateral papilledema, but is fully oriented and coherent. He has been known to be hypertensive for about 5 years and his blood pressure control has been good on 3 drugs. However, he had decided to stop all the medications 2 months before this event. Which of the following would be your preferred parenteral medication at this point? So, what are the points that you need to know here? Blood pressure is very high. Right? Blood pressure is very high. And along with that, there is bilateral papilledema. So, what do you want to give now? What is your preferred parenteral medication at this point? Shankar Deepu, you want to give phentolamine. And Vaibhav also says that he wants to give phentolamine. Okay, so everyone want to give phentolamine. Oh, we have a change. Madhuri Venkatakishore wants to give labetalol and Rakshita Narayan wants to give metoprolol. Okay, so your C, D, E options are selected. Anyone want to select any other option? The answer here is, right, the answer here is glyceryl trinitrate. The answer here is glyceryl trinitrate. The answer is A. Now let me tell you, this is a case of hypertensive crisis. Right, this is a case of the hypertensive crisis. So in hypertensive crisis, previously, right, previously we were using nitroprusside, but this nitroprusside is no more used now. Right, this nitroprusside is no more used now. But apart from the nitroprusside, what is the next agent which is preferred in order to see that the blood pressure has to be reduced? The next agent what we have to give is glyceryl trinitrate. The next agent what we have to give is glyceryl trinitrate. And this glyceryl trinitrate is very much efficacious in reducing the blood pressure in case of hypertensive crisis. Right, it is very much efficacious in reducing the blood pressure in hypertensive crisis. Okay, now, and many of you are answering about the phentolamine. Let me tell you, this particular phentolamine is used in hypertensive crisis in a patient with a pheochromocytoma, but not in all the patients. So in a pheochromocytoma, you have to give this particular phentolamine, right? But not in all the cases of your hypertensive crisis. So in this clinical scenario, what is that you have to give? You have to give the glyceryl trinitrate. That's an ideal agent to reduce the blood pressure in a patient with a hypertensive crisis. So please remember this point, very, very important point, right? Okay. So what is the take home from this question? The take home message from this question is, hypertensive crisis, ideal agent to reduce the blood pressure, we need to give glyceryl trinitrate, right? Vaibhav Trivedi, you should not confuse with one point. What am I telling you? When will you give phentolamine? You have to give phentolamine if there is hypertensive crisis in pheochromocytoma. But in pheochromocytoma, if there is no hypertensive crisis, right? If there is no hypertensive crisis, then what is that you have to give? The alpha blocker, that is phenoxybenzamine. Right? Alpha blocker, that is phenoxybenzamine. Okay? So if it is not hypertensive crisis, then give phenoxybenzamine. But if it is hypertensive crisis in pheochromocytoma, you have to give phentolamine. Yes, Vaibhav Trivedi, did you understand this point? Yeah, yes, Shankar Deepu, you are, yes, even during surgery, this phentolamine is used. If there is any hypertensive paroxysms, if there is any hypertensive paroxysms, we use this particular phentolamine, right? Now, okay, so you see this question. The child shown below has which particular heart disease? You see the facial appearance. Just can anyone describe what is that facial appearance? And accordingly, you should be able to decide which particular heart disease is there in this patient. Endocardial cushion defect, partial anomalous pulmonary venous connection, patent ductus arteriosus, tetralogy of Fallot. Right, very good, Sai Shankar Deepu, what did I tell you? I said you that nitroprusside is no more used nowadays. Nitroprusside is no more used nowadays. That is what I have said you. Right. So very good, Sai Tarni. Sai Tarni has answered it correctly. Endocardial cushion defect. Right. So this is a classical appearance of a face of what you have a mongoloid slant of the eyes. Right. And you have that saddle nose and the happy posing baby. All these points are in favor of your Down syndrome. Very good, Tenso. Excellent. Okay. So all these points are in favor of the Down syndrome. So in Down syndrome, what are the congenital heart diseases that can be expected? Atrial septal defect and as well as the endocardial cushion defects. Right, endocardial cushion defect. So the answer here is endocardial cushion defect because ASD is not there in your options. So what will be the best answer? If atrial septal defect is not there, the next best answer will be your endocardial cushion defect. Right. So that mongoloid slant eyes, happy posing baby, and as well as the saddle nose. All these points are in favor of Down syndrome, which is associated with ostium primum type of ASD and or the endocardial cushion defects, right? So the answer is A, that is endocardial cushion defects. Right. You see the next question. A previously fit 39-year-old man presents with unusual shortness of breath on exertion. At times, this is also associated with exertional palpitations. On examination, there is loud mid-diastolic murmur at left sternal edge. Her heart rate is 122 per minute. Blood pressure is normal and there is no edema. ECG shows atrial fibrillation. Which of the following would be the clinical finding to assess the severity of this patient? Ejection click, long gap between A2OS, loud S1, long duration of the mid-diastolic murmur. Okay, so can anyone tell me what is the diagnosis, Nirbhay Kumar? What is the diagnosis? Right. So very good, Nirbhay Kumar. So the diagnosis of this patient is mitral stenosis. Diagnosis of this patient is mitral stenosis. So now why? Why do you think it's mitral stenosis? Presence of, right? Presence of loud mid-diastolic murmur. Right? Presence of loud mid-diastolic murmur. Right? And at the left sternal edge, that is one point. Next, atrial fibrillation is one of the complications of your mitral stenosis. And what will be the clinical feature in mitral stenosis? Shortness of breath. And why do you think that the patient is having palpitations? Because the patient is in atrial fibrillation. Because the patient is in atrial fibrillation, there will be palpitations in the individual. Okay, now in mitral stenosis, what are the points which will assess the severity? Right? Remember, in mitral stenosis, you will have an additional sound. And what is that additional sound? That is opening snap. Right? The additional sound is the opening snap. Now, what is this opening snap? Why is this due to? Opening snap, it's a diastolic sound. Right? Opening snap, it is a diastolic sound. It is an additional diastolic sound what you will have in mitral stenosis. And why is that you will listen opening snap? Due to opening of stenosed mitral valve. You take in a normal individual. Opening of the mitral valve does not produce any sound, but opening of stenosed mitral valve will produce an additional sound that is called as the opening snap. Now, you take A2OS. A2OS gap should be narrow. It should not be long. It should be narrow gap. So, narrower is the gap, severe is your mitral stenosis. I'll repeat this. Narrower is the gap, severe is your mitral stenosis. Right? Next. The second thing which will tell you the severity of your mitral stenosis is the duration of the mid-diastolic murmur. Long duration of the mid-diastolic murmur, it also tells you that the patient is having mitral stenosis. So these are the 2 points which will assess the severity of mitral stenosis. Number 1, narrow A2OS gap. Number 2, long duration of mid-diastolic murmur. And other point in favor of the mitral stenosis in this patient is the heart sound is not mentioned. Okay. Now I just want to ask you one point here. In atrial fibrillation with mitral stenosis, can anyone comment on first start sound, how it will be? Can anyone comment on the first start sound, how it will be? Yes, any one of you? How will be the first start sound in mitral stenosis with atrial fibrillation? Any one of you, please? Very good, Nirbhay Kumar. It will not be loud. Bhargav, it will not be loud. You will have variable S1. Why? Because the patient is in atrial fibrillation. Otherwise in mitral stenosis, right? Otherwise in mitral stenosis, let me tell you, you will have loud S1. That is accepted. But here, along with the mitral stenosis, the patient is in a state of atrial fibrillation. So when the patient is in a stage of atrial fibrillation, so what will you have is variable S1. What will you have is variable S1. Okay. So the answer here is the long duration of mid-diastolic murmur. Right? Now, the last question for the day. Yeah. We have a 69-year-old woman, right? We have a 69-year-old woman admitted to the coronary care unit with unstable angina, right? With unstable angina. She started on appropriate medication to reduce the cardiac risk. She is hypertensive, fasting glucose is normal, and cholesterol is 159 milligrams per deciliter. She is found to be in atrial fibrillation, right? She is found to be in atrial fibrillation. What is the most appropriate treatment for her? What is the most appropriate treatment in her? Aspirin and clopidogrel, digoxin, cardioversion, aspirin alone, warfarin. You want to give digoxin, Saitharni? Okay. Now, this is the patient. No, I did not get the correct answer from any one of you. Right. So, everyone should be aware of what is called SHA2, DS2, VAS scoring system. Right. So, everyone should be aware of what is called this SHA2, DS2, VAS scoring system in atrial fibrillation. Okay. Now, what is this CHA2 DS2 VAS scoring system? And depending upon your CHA2 DS2 VAS score, you will decide the treatment. You have to decide the treatment. Very good. Now, Sai Taruni has come up with the correct answer. Now, the answer is warfarin. What is this CHA2 DS2 VAS scoring system? Let me explain you. So, this is your CHA2 DS2 VAS scoring system. C stands for congestive heart failure. If the patient is having congestive heart failure, give a score of 1. H, hypertension. If the patient is hypertensive, give a score of 1. Our patient is hypertensive, right? We will give score as 1. Our patient is hypertensive, give a score 1. Next, A2. What is A2? Age more than 75, give a score of 2 points. But our patient age is 69 years. Okay. D, diabetes mellitus is there, give a score of 1 point. S2, if the patient had stroke, give 2 points. V, vascular disease. If the patient had any vascular disease, give a score of 1 point. Now, what did I tell you? Our patient has unstable angina. So, unstable angina means it's a coronary artery disease, which is a vascular disease. Give 1 more point. Age more than 65 years, give 1 point. Our patient age is 69 years. So, give 1 more point. Next, if she is a female, give 1 more point. So, our patient is a female. So, what is the total score? Total score is 4. So, in this patient, let me tell you that there is chance of so more is the score, right? More. What is the importance of this score now? More is the score, more is the chance of thrombus formation. Right? More is the score, more is the chance of thrombus formation. So, if the score is 0, then no therapy or aspirin should be given. But if the score is 1, you need to give aspirin or oral anticoagulants. But our patient is having a score of more than or equal to 2. More than 2 is our patient score. That is 4. So what you have to give in this patient? You have to give oral anticoagulation. Why you have to give oral anticoagulation? To prevent the thrombus. To prevent the development of thrombus. See, what are we very much worried? So, in this patient, you need to give warfarin. So, what are we very much worried in patients with the atrial fibrillation is, we are very much worried about the thrombus formation. If thrombus is formed, what is the problem? If thrombus is formed, we are very much worried that it can give rise to an emboli, and wherein the individual may land up in embolic stroke. The individual may land up in embolic stroke. So that is what I am very much worried about. So that is the reason why I will give warfarin to this patient. That is the reason why I will give warfarin to this patient. Now, how should I control this atrial fibrillation? So, for atrial fibrillation, the drugs that can be given is, we have 2 types of drugs in atrial fibrillation. 1, rate control, and 2, rhythm control. Second one is rhythm control. Now, for rate control, what should I give? The drugs what I should give for rate control in atrial fibrillation is beta blockers. Then calcium channel blockers. Then, if not controlled with your beta blockers and calcium channel blockers, then you can give digoxin. Then you can give digoxin, right? But for rhythm control, what is the drugs you will give? Rhythm control, what you can give is amiodarone. Then the other important drug that can be given is ibutilide. Okay, so these are the drugs that can be given for rhythm control of the individual. These are the drugs that can be given for rhythm control of the individual. Now, in this patient, what are we very much worried? She started on appropriate medication to reduce her cardiac risk, right? But we are very much worried about the thrombus formation, and we don't want any embolic stroke. And that is the reason why you need to give the warfarin to this particular patient, right? Next. Now, and not only that, in case of atrial fibrillation, you should also treat the underlying cause, right? You should also treat the underlying cause. And the most common cause of atrial fibrillation is, right? Most common cause of atrial fibrillation is hypertension, right? Now, can anyone tell me what is the endocrine disorder which can cause atrial fibrillation? Any one of you, please? What is the endocrine disorder where you can have the development of this atrial fibrillation? Anyone? Any one of you? Right. Let me tell you that. Endocrine disorder which is associated with the development of atrial fibrillation is thyrotoxicosis. And other condition where you can have is pheochromocytoma. Other condition where you can have is pheochromocytoma. So these are the conditions, endocrine conditions where you can have this particular atrial fibrillation. All right. I'll give you a quick review of take-home messages of all the questions. Right. Take-home message of this question is that, remember, rheumatoid arthritis, cardiac complication is constrictive pericarditis. This is a take-home message of this question. Take-home message of this particular clinical question: widening of anterior mediastinum on the chest X-ray. Think of aortic dissection. That is a take-home message of this clinical question. Next, very important. What is the take-home message of this particular clinical question? Constrictive pericarditis can occur after coronary artery bypass graft after a very long duration. See, this patient is having, this patient had a CABG 20 years back, and now the patient has developed the constrictive pericarditis. That can happen. But what is the most common cause of constrictive pericarditis in India? Tuberculosis, right? Next, what is the take-home message of this question? You have deep Y descent and deep X descent. You will see that in constrictive pericarditis. In cardiac tamponade, remember, you will not have this Y descent. You will not have the Y descent in cardiac tamponade. Next. Yes. And what is the take-home message of this question? In accelerated hypertension, the ideal drug to reduce the blood pressure is nitroglycerin. Whereas hypertensive crisis in pheochromocytoma, the ideal drug to reduce the blood pressure is your phentolamine. All right. Next. Yeah. So the take-home message of this question: this patient having Down syndrome, what are the congenital heart diseases you can have? Ostium primum, ASD, and endocardial cushion defects can be there. Okay. And ASD is not there in your option. So that is the reason why endocardial cushion defect is the answer. Next, what is the take-home message of this question? This is a case of mitral stenosis. And mitral stenosis, you will assess the severity of mitral stenosis clinically by two ways. Number one, short A to OS gap. Number two, long duration of the mid-diastolic murmur. Right? Next. And what is the take-home message of this particular clinical question? This is a case of atrial fibrillation, and the take-home message is about the CHA2DS2 VAS scoring system. If CHA2DS2 VAS scoring system is 0, no therapy or aspirin can be given. If it is 1, you need to give aspirin or anticoagulant. But if the score is more than or equal to 2, you need to give oral anticoagulant. And the CHA2DS2 VAS scoring system of our patient is 4. You definitely need to give the warfarin therapy. So these are the clinical questions on the topic of the cardiology. And tomorrow I'll see you again to discuss some more clinical based questions. Until then, thank you, good night, and see you tomorrow again.